As you may know, when chronic dialysis was started in 1960 in Seattle and was a completely scarce resource, there was a very famous committee that was formed to decide which patients would get it. Because there were a lot of patients who needed it and they didn't have enough facilities. So there was a committee with doctors, nurses, social workers. There was also a priest, and there was a judge, and there was a laborer. And this committee met to decide whose life was worth more than someone else's life to get this procedure. Well, in 1967, when the big unit started, we also had a committee. It wasn't as scarce a procedure, and we had doctors and nurses and social workers, nutritionists, and we had one rehabilitation expert. But yeah, we had to meet with every patient, whether it was an adult or a child, was presented to this committee and decided whether they would be able to get the procedure or not. Fortunately, at that time there were enough beds in this new center that almost everybody that needed it got in.
And in those days, they were what we call parallel plate dialyzers. Now they're tubes, they're different, but the parallel plate dialyzers had to be taken apart, cleaned every night, and you could put in more plates for bigger children. And the story was that he spent his days cleaning the plates and his nights dialyzing the child in the intensive care unit. There was only hemodialysis, and the access was different. In those days, we used what were called shunts. You'd start down here, and you'd find an artery and a vein in, say, the wrist, and you would take a plastic tube and run it out of the artery in the vein, and the tube would be held together, and when they would come in for dialysis, you'd put clamps on the two ends of the tube, which were outside the body. You'd spread them apart, and you'd hook them up to the machine. We had some kids who lived in very bad neighborhoods and went to school in bad neighborhoods. They had to be completely covered with gauze so that someone wouldn't take a knife and just cut through those things. Well, they only had a very finite lifespan, and you'd work your way up from the wrist to the elbow, further up, and unfortunately, pretty soon, if you couldn't dialyze the child or if they came back to dialysis, you'd literally run out of places to dialyze. The concept of fistulas and grafts being put on came after the shunt.
I think among the greatest obstacles were the feelings of many, including pediatricians and including some pediatric nephrologists, that young children with progressive kidney disease and kidney failure should not really be offered care. I remember vividly a discussion in the lunchroom when I moved home to Boston with 3 children under 2 at the time, that a particular young child we were following shouldn't be offered a transplant, and one of the clinicians, not a pediatric nephrologist, but someone who did see many patients with us, a pulmonologist, said, why not go back to the drawing board? These parents are young, they should just have more children. And that was a starkly stated, prevalent viewpoint. So I think overcoming that and finding ways to differentiate pediatric nephrology from internal medicine nephrology and to consider the whole child and do that routinely was an uphill battle.
Well, when I started in the 70s as a fellow and then initially as a nephrologist, dialysis and transplantation were not universally available at every center. In fact, not every center believed they needed a nephrologist. And I was fortunate to train in Seattle, where the peritoneal dialysis was starting at the time. We just, during those days, we tried everything to prevent end-stage renal disease, things that, because now it would be seen excessive, but we just a child who reached end stage often died. And as new techniques came along, we would try. I used a double barrel Cook catheter to try peritoneal dialysis. We started infant dialysis in Memphis, never been done before, and trying to work through the complications and then the feeding problems with those infants, and adapting adult machines. My mentor and I tried one time as a fellow we read an article about someone who used intestinal dialysis in an underdeveloped country to try and rehydrate someone and to recover from acute renal failure. And this baby had had abdominal surgeries, and we couldn't do any kind of dialysis. So he and I tried using the colon as a dialysis membrane, and unfortunately it wasn't successful. But we were just really looking at any way we could try and keep kids alive with very, very limited technologies available to us.
That was the Gottschalk Committee, I think it was in 1972, and they went to Washington. They actually performed a dialysis in the House of Representatives to show the congressman what this procedure was all about and how it saved lives. And as I say, Dr. Holliday was a member of that committee, and that allowed the funding and allowed dialysis and transplantation to take off.
Well, things were much less controlled and regulated back then. If they felt something was in the best interest of the patient, they could usually make that happen. Dr. Hickman in particular was kind of a cowboy, and he would go way beyond what was considered the norm, helping Dr. Tenkoff to fashion very tiny peritoneal dialysis catheters for infants. I mean, no one thought that could be done. He had some transplant patients who needed some drugs, such as erythropoietin, that were available in Europe but not in the United States yet. He arranged to get it in Europe for these patients. So there was a lot more of that sort of almost experimental medicine that went on that is really not possible today without a lot of red tape and rules and regulations, some of which are needed and are appropriate, but some of which really do slow down progress.
One particular night I remember so well. I was a second-year resident, and we had a child in heart failure, intractable heart failure. She was less than a year old. I don't remember exactly how old now. And it was from severe hypertension. And in 1973, the only intravenous antihypertensive was apressylene that was available. And it was just, she was dying of heart failure. And I had just read this article about this new drug called diazoxide, Hyperstat, and Dr. Hickman came in and we were trying to figure out what to do. And I said, Dr. Hickman, do you know anyone that has access to this medicine? Or he said, I think somebody over at the VA has an IND for that. Let me call. So he called, and he said, yeah, they're going to send some over by taxi. So they sent this drug over with no, thinking of it now is just unbelievable because we didn't have an IND, an IRB, and it came and we looked at it and he said, how much do you think we should give? And I said, well, I don't know. The dose in adults was, I think, 5 milligrams per kilogram. And I said, shall we try half a dose? And he said, might as well. So we gave the dose, and all of a sudden the monitors started going berserk, and he said, oh my God, Bruder, I hope we didn't kill this baby. And the blood pressure came down and stayed down. Renal function recovered, and it just took that one dose. But just that idea that in those days there were so limited pharmaceuticals, there were so little thought about safety and controls, and it would be totally inappropriate to do something like that now. But it saved this child's life, but it was sort of a glimpse into where we are now and 40 years ago.
Actually, transplantation became viable in 1959 for the first time, and the first child received a transplant in 1962 in Denver. Our program at UCSF started in 1964, and a few transplants had been done in teenagers when we got there in 1966. The procedure was the same as it is now. However, the immunosuppressive drugs were much less effective than what we have now. So that the rejection rate was much higher, and 50% of children who received transplants from a family member had lost, or 55% would have lost their kidneys by 1 year, and 65% of those who got cadaver kidney would have lost the transplant within a year. So yeah, it was mainly that the drugs were not nearly as sophisticated and as good as they are today. Also, a lot of the ancillary things that we use in medicine and transplantation, like ultrasound, wasn't available. CT scan wasn't available. But despite what I've said, most of the children most of them lived after transplant, although the mortality rate was higher than it is now. And a lot of them got second or even third transplants. And it was all new, and before this, all of these children would have died before dialysis and transplantation. And now a lot of them were living, and a lot of them were living very normal or very satisfactory lives. So it was, it was a wonderful advance. And I will tell you that some of the children that received transplants around 1969 or 1970 still are alive with their transplants today. Not very many, but more than 40 years.
It's been unbelievably exciting. I guess you'd put me in the 1.5 or second generation of pediatric nephrologists. I learned from people who did not come from formal training programs. Training programs were literally being established. The journey has been fantastic. We have the opportunity to care for this unique field of patients. We're not the only group, but we can take patients, we can take children, infants from birth, we can follow them throughout the pediatric years, we can develop immensely strong relationships with them and their families, and we can actually now see these kids grow, develop. We now have kids with chronic kidney disease who are taller than I am. That would never have happened early on. It's a little annoying to look up at them, but it's great, all right? And they go on to college. I tell my parents, the parents of my children, start putting money into your college education fund. They're going to need it. That never happened before. I can only imagine the changes that will occur over the next 10, 20 years. I'm jealous that I'm not going to be around to see them necessarily, but I think there are still problems in pediatric nephrology, but the pace of improvement has really moved on and continued. It's a great place to be in, a great field to be in.
You know, I recently received a email from a boy who's now a young man, and he included 2 pictures of children. And he said he found me on the internet, and I remembered him very well. He had a very challenging condition that we were able to create a research protocol and essentially cure him of his condition. And at the time, there was no proven treatment. And he came from a disadvantaged background, and we were able to get the CRC to pay for the treatment that ultimately put him into permanent remission. And if we hadn't done that, he would have died, I think. And secondly, he would never have had a family. And he wrote me to thank me for helping him through that time, and it made everything I've done worthwhile. You know, the opportunity to help really challenging patients to have a better life is so rewarding. In pediatric nephrology, you have to be a complete pediatrician, and just to be able to use all your training to help people and see the results of your care. Certainly there are occasionally bad outcomes and sad situations, but the opportunity to really make a future for people and to do it in such an interesting, for me, field as nephrology is makes it a great career.